Okay, I guess we can go ahead and get started. Welcome again to the Epilepsy Podcast, and we're really excited today to have Dario Englot as our. And Dario, can you pronounce your last name for me just to make sure I'm saying it right?
Sure, Englot.
Englot. Okay,
Yeah.
Dario Englot. Great, thanks, Dario.
Of course.
As our guest today, Rohit, you want to go ahead and introduce Dr. Englot and talk about the topic for today?
Sure, it'd be my pleasure. Dr. Dario Englot is an associate professor of neurological surgery, neurology, radiology, and radiological sciences, and the surgical director of epilepsy at Vanderbilt University Medical Center. Dr. Englot's clinical interests include epilepsy, neuromodulation, movement disorders, pain disorders, and general neurosurgery. He also leads an active research laboratory studying brain networks in neurological disorders using neuroimaging and electrophysiology, with a particular focus in epilepsy. Dr. Englot completed his residency at the University of California and his fellowship in functional neurosurgery and epilepsy at Vanderbilt. Today, Dr. Englot is going to be sharing his knowledge in how to use the knowledge of the human brain connectome to guide epilepsy treatment. Thank you for joining us, Dr. Englot.
Yeah, thank you so much for having me. I appreciate it, and I appreciate you putting together this podcast.
Great. Rohit, why don't you get us started?
Alrighty, sounds good. So Dr. Englot, to start us off, our traditional understanding of focal epilepsy involves an epileptogenic zone. And we define this epileptogenic zone as an area of cortex necessary and sufficient for generating seizures, and whose removal or disconnection will generally lead to seizure freedom. What is wrong with this definition, and what are we missing in this traditional model of epilepsy?
Yeah, I think it's a great question that we're really just in the process of understanding. Yeah, of course, this traditional model thinks about focal epilepsy as one discrete focal area of the brain that becomes abnormal and then starts to generate seizures and push those seizures out to the rest of the brain. But when we think of epilepsy surgery, success rates, are far from 100%. There could be maybe 60, 70%, or depends on the type of surgery. But if we're the fact that it's not perfect either means, number one, we're either not doing a very good job of localizing this EZ, or number two, it's more complicated than that. And I think both have merit, and both sometimes are partially true. But for sure, it's more complicated than that, and meaning that we're really learning that epilepsy is a brain network disorder, even focal epilepsy, and that I think what we identify typically as the epileptogenic zone is likely a very important node in this network. But it's clear that removing that node is not going to stop all the seizures or cure epilepsy in all patients. And so we need to start thinking more broadly about epilepsy as a network disorder so that we can improve our treatments and of course, improve our success rates. Luke, I think you're on mute if you're talking.
Sorry about that. When
Sure.
it comes to understanding connectivity in the brain, it sounds like advanced neuroimaging is playing a big role in our understanding of brain connectivity. Can you talk about the role that diffusion tensor imaging and functional MRI and resting state MRI plays in us trying to understand connectivity? And can you also talk a little bit about, in patients with epilepsy, what do we know about regional connectivity in the epileptogenic seizure onset zone as opposed to connectivity in remote regions of the brain?
Right. Yeah. So that's a great question. So, when I think about brain connectivity, and network analysis really is centers around brain connectivity analysis. And I think about functional connectivity, structural connectivity, and effective connectivity, where structural connectivity, like you mentioned, diffusion weighted imaging, is really the anatomical axonal pathways that we're studying, the kind of like the highways of the brain. Functional connectivity looks at the neural signals in those different brain regions and see how similar or different they are to infer functional connections. And so it's more like the traffic on the highway, so you could have a busy highway with a lot of traffic, or you could have a small road with a lot of traffic, or you could have a big highway with almost no cars. So there's relationships, but not one-to-one relationships. And then effective connectivity is really the direction of that traffic, which way is it going? And what we're learning about, there's definitely fingerprints of epileptogenic regions in connectivity analysis that are improving our ability to localize these networks and to plan treatments. However, those fingerprints differ depending on the analysis method you're using and also on the modality that you're using. So for example, in functional MRI, which is really dependent on hemodynamic signals, we often see a decreased functional connectivity at epileptogenic zones, which maybe is not surprising because we know these are areas that are often hypometabolic and functioning abnormally, unpet, that's right. On diffusion weighted imaging, oftentimes we do see microstructural damages in this area, so structural connectivity damages. But in intracranial EEG functional connectivity analysis, which is obviously very different, much higher frequency sampling rate and a more direct measure of neuronal activity, the EZs often have very high functional connectivity compared to other regions of the brain. And right now what we're learning in using, as I mentioned, effective connectivity analysis, it seems to be specifically that the high functional connectivity is driven by high inward functional connectivity from non-epileptic to epileptic regions. And there's actually lower outward effective connectivity at rest. And so what our hypothesis is that this may be at the interictal time between seizures, inward inhibitory connectivity that prevents seizure onset, perhaps as an evolutionary mechanism, and perhaps one of the reasons why an individual with epilepsy is not always having a seizure. It's because there's likely this compensatory inward inhibition. We could potentially use this to our advantage because understanding these connectivity fingerprints can help us better find these areas and plan surgery.
It's an interesting point. Why indeed does a patient with epileptogenic cortex, why aren't they always seizing?
That's right. Yeah.
And what you think is that there's some inhibitory kind of constitutive inhibitory activity on that brain from the rest of the brain, basically.
Yes. Yeah. Our work is suggesting that, and a number of other groups are now showing work with intracranial EEG analysis that suggests that. And there's also basic science animal model evidence of that that would support that too. So I agree. It is really interesting.
Rohit, why don't you take the next one?
Sure. Dr. Englot, we know that seizures, and this kind of like touching on what you were just talking about before, we know that seizures can and typically do spread throughout the brain. In the early days, by looking at evolving semiologies, and more recently by placing depth electrodes and studying the stereotactic EEG, we can, in a sense, visualize these spread patterns. Has our research into brain connectivity shed light onto how seizures spread and generalize?
It's early, but it's definitely helping us learn a little bit more about how seizures spread and what pathways they're going to spread by. Some of the work we're working on now, intracranial EEG analysis, suggests that there seems, as I mentioned, high connectivity at areas where seizures start, but there seems to still be elevated, but not quite as elevated connectivity at the areas where they propagate more quickly. And then the areas that are involved most late or not involved at all in the seizure have some of the lowest connectivity. So there seems to be this gradation of high towards low connectivity along seizure propagation zones, which is helpful because it's helping us to identify those seizure propagation zones and predict them. And in particular, early seizure propagation areas oftentimes may be involved in what you would need to remove when you define the epileptogenic zone. Maybe a seizure onset zone, and then a very early propagation zone could make up what we traditionally think of as the epileptogenic zone and want to remove. So these these connectivity biomarkers of spread, I think, are helpful to us. But this is, again, we're just seeing the tip of the iceberg right now. And then the other thing is that overlaying structural connectivity and functional connections is also helping us understand spread patterns too, because it seems like there's complementary information in functional and structural connectivity that we can use to, when we overlay them, really better predict which way seizures are likely to spread.
So Dario, with all these connectivity theories, we do still see that simple removal of the epileptic zone with surgery does afford us pretty good seizure freedom rates. Like you mentioned, it's not 100%, but 60 to 70% in patients with temporal lobe epilepsy, maybe 80 to 90% in some patients who undergo removal of a low-grade epilepsy-associated tumor, or even in hemispherotomy surgery. Should we better understand surgery as disruption of a network as opposed to removal of an epileptogenic zone?
Absolutely. I definitely think we should. And we also shouldn't think of that network as static, but as something that evolves. And so I think the reason we have high success rates in, for example, mesial temporal of epilepsy surgery is clearly the hippocampus in that case is likely the most important node in the epileptogenic network. We know that seizures spread throughout the limbic network beyond the hippocampus, but that's clearly the most abnormal anatomical location. And removing that, what it likely does is at least removes a very important node in the network, and that might be enough in many patients, probably the majority of patients, to stop seizures. But then, and when we think of failure, there's really two categories of failure. We see some patients who are still having seizures immediately after surgery, maybe fewer seizures, but so clearly we disrupted the network if the seizures reduced, but we didn't disrupt it enough to stop all the surgery. And there's also other parts of the network that are still active in generating seizures. And then we oftentimes seen patients who are completely seizure-free for a while after surgery and then have later recurrence. And to me, what that likely represents is that the network has continued to evolve in a pathological way, and other nodes in the network that by themselves may not have been enough to generate seizures at the time of the resection, over time as the network evolves, begin to that network is now primed to generate seizures even without the primary node that you removed. So absolutely we should be thinking about epilepsy surgery as network disruption.
And Dr. Englot, some studies have shown or claim to show that connectivity of the brain as determined by pre-surgical whole brain diffusion tensor imaging might predict postoperative outcomes in some patients. For example, those undergoing temporal lobectomy. Your own paper from the journal Brain Communications describes a favorable connectome fingerprint. Tell us about this work, and if you think that diffusion MRI should have a role in the standard pre-surgical workup to help identify optimal candidates for epilepsy surgery.
Right. Yes. It's a great question. So that paper and a few related papers are led by my research partner, Dr. Vicki Morgan, she's an engineer here at Vanderbilt. And when I came here to do my fellowship, I also did 50% postdoc training with her to really learn how to do better fMRI and diffusion-weighted imaging studies in epilepsy. And the two of us have since then collaborated very closely. So we work on these projects very closely together. And this idea is really hers. And it really is in mesial temporal of epilepsy, a cohort of patients who are very homogeneous. And here in Tennessee, we still see a very high proportion of mesial temporal of epilepsy, even though at a lot of bigger cities that seems to be less prevalent these days. But in the ones who are very homogeneous with unilateral seizure onset, positive PET, possibly MTS on MRI, classic semiology, even in those patients that are slam dunks, we're still seeing 2/3 seizure freedom and about 1/3 that are still having seizures. And so that's almost like an ideal population to study networks, because everything else seems to look the same. And clearly what seems to be different is not the usual things we're looking for. It's something different with the network. And so that's what these network fingerprint studies that Vicki has been working on, and I've been helping her closely, are looking at, is combining. Some have looked at both functional and some is structural, but really the best fingerprints seem to be combining both diffusion-weighted imaging and as well as functional MRI connectivity patterns, and identifying what does the network look like in a patient who does really well? What does the network look like in a patient who fails surgery, even though all the preclinical data looked exactly the same? And can we identify that connectivity fingerprint that then we can use to help predict outcome? And of course, the idea ultimately will be then to use that clinically, have that be the connectivity fingerprint, an additional test that we look at in the pre-surgical patient, because it's clearly adding more predictive value that we are missing when it comes to just our standard pre-surgical tests.
Dario, have you started doing this in your own practice? Is diffusion tensor imaging something that you guys are looking at for your own clinical practice?
The answer, we have tested it in a few patients, and we've run a few patients through the pipeline and informally had discussions about what we think this patient will what their outcome will be like. But the bigger answer is really, unfortunately, no. It's not dramatically altering. It hasn't dramatically altered our practice yet, and that's actually something I'm really interested in. And so I have a role as in the International League Against Epilepsy. We have a Surgical Therapies Commission, and one big goal in the Surgical Therapies Commission in this term is to understand what are the barriers to applying network neuroscience studies like that, like this fingerprint study, clinically, and what's preventing us from applying it clinically, and what do we need to do to get there? Because as we mentioned, clearly it's going to add something. So how do we overcome so for example, that study, it hasn't been externally validated. So we have not yet had collaborations with outside centers with in the Dr. Morgan's study that is externally, and that is one of the barriers. Other barriers are just we have so many models from so many different centers. We have different patient types in different studies, and so there's a number of things we need to do to bring ourselves together, and equipment's differences too. Expertise of technicians. So there's a number of steps we need to take to really start to use this stuff clinically, and there's a lot of interest in the ILAE and through other societies to start to try to make that happen. I do think it's going to be on the horizon soon, because it's clearly going to add more value to our decision making. But have we crossed that threshold yet? For the most part, no.
Not yet. Now, we've talked a lot about focal epilepsy, but tell me a little bit about generalized epilepsy and multifocal epilepsy. Obviously there's been increasing interest in the thalamus as a potential node in these seizure networks. Mm-hmm. Can you talk about have you sort of uncovered anything in your own research, or what are your own thoughts about the thalamus as a seizure generator, or is being part of that node or part of that network? Excuse me.
Right. Yeah. So in my lab, we have looked at thalamic connectivity in multiple aspects in focal epilepsy. We have not yet studied generalized epilepsy, which I think is a strong interest of ours, and one that we're about to start. There's a responsive neurostimulation Nautilus trial that we are a site in, and so we will have a number of patients coming through the surgical pipeline that I think we have the ability to start doing some connectivity analyses in those patients. But other groups have looked at thalamic connectivity in generalized epilepsy, and also in secondarily generalization. And it's clear that thalamic connectivity profiles differ in patients who are much more likely to generalize, and it's clear that thalamic connectivity profiles are altered in generalized epilepsy subsets. And I think the exciting thing about this clinically is that starting to understand these thalamic hubs better is opening up a window for surgical therapies for patient groups, generalized epilepsy patient groups that make up about a third of the drug-resistant patients that previously didn't really have any surgical options other than vagus nerve stimulation and potentially disconnection for certain patients who have rapid contralateral spread. But thalamic stimulation, I think, is going to be a big part of both focal and generalized epilepsy. We see obviously anterior nucleus stimulation helping with the frontotemporal limbic epilepsy. Perhaps some early evidence pulvinar stimulation can help in posterior quadrant epilepsy. Right. And centromedian nucleus in the thalamus, which is an intralaminar thalamic nucleus that has very broad projections throughout the cortex, seems to be a very interesting target for primary generalized and also symptomatic generalized epilepsy. And now there's a few smaller studies that have shown really promising results of CM stimulation using either open or closed loop paradigms in substantially reducing seizure frequency. And now, as I mentioned, there's clinical trials right now in the early stages for both the idiopathic generalized epilepsy and symptomatic generalized LGS patient subtypes. And I think clearly the CM is a major hub in generalized epilepsy, and probably deactivate, at least quieting down that hub, deactivating that hub a bit with stimulation is going to have a favorable effect on seizure frequency for a number of patients. And obviously we're in the very early stages of this, but I think it's neat that we're finally getting some surgical therapies for these patients.
Thank you, Dr. Englot. For our next question, what do we know about how or whether VNS, RNS, DBS modulate the connectivity of the brain, and whether this is part of the mechanism of how they impact seizure frequency?
Yes. So the short answer is we don't know that much, but we do have some early ideas. The classic VNS studies really came from studies stimulating the vagus nerve of cats and during intracranial EEG, EEG, and noticing that it caused desynchronization, and that led to early studies of trying to see if it would help epilepsy. And so that's probably what it does. Stimulating the vagus nerve through mechanisms that we don't understand seems to lead to generalized electrographic desynchronization, and it's probably why VNS has efficacy across a very broad array of seizure disorders, not focal epilepsy, multifocal epilepsy, even generalized epilepsy, because it seems to be just a generalized desynchronization of the electrographic pattern. Now, it doesn't, in the vast majority of patients, that's not enough to prevent all seizures, but in many patients, it is have a very beneficial palliative role. Neuro RNS, we're also just learning. Obviously, the idea with the invention of RNS is identify early electrographic patterns that indicate the beginning of a seizure and shock the brain out of that pattern. And I think sometimes, we know that sometimes that's how it works, because we see oftentimes early electrographic epileptiform activity and then a stimulation and then we don't have a seizure. So it works. But some work, particularly that Mark Richardson's done out of MGH, has noticed that actually doesn't work like that the most of the time. It seems most of the time the individual seizure is not being stopped, but with that intermittent stimulation over time, that's likely modulates the network and begins to have a long-term beneficial effect that network now becomes less likely to create seizures. So some aspects of it are similar to DBS, which, as you know, is an open loop constant stimulation that's oftentimes programmed like VNS, perhaps a minute on or 30 seconds on and then 5 minutes off, but there's no feedback from it. But it works pretty well if you find a favorable target. And so I think both of them obviously are creating long-term modulation in the network. All neuromodulation therapies seem to have improved efficacy over time, which further suggests that it's the continued modulation of the network that's leading to the benefits. But in detail beyond that, we really just don't know. It's really early in the field to know, quote, how is it working.
All right, Dario, I think we're going to wrap it up here in a little bit, but I'd like to finish with just a question about, you were an MD PhD, is that correct?
Yes.
Right. So, I listen, I see you in the field as one of the few guys, I think, who's really doing, has a very busy clinical practice, but's really deeply involved in the research. And tell us about how you've been able personally to strike a balance in your career and in your practice, and how do you have time for anything? I'm just curious.
Yeah. Well, one thing, I really enjoy it. I don't think I would enjoy it as much just doing clinical work, and I certainly wouldn't enjoy it as much not only doing research and not seeing patients. And so obviously loving both is needed to do both. The way in my PhD, I did mostly animal work, and then coming in at that time, I thought probably maybe I'll be a neurologist scientist with maybe half a day a week of clinical work. Once I realized my passion was really in functional neurosurgery, and I realized, well, I'm not going to be spending 80% of my week doing research. I do spend about 50% research, 50% clinical time, and that's when I really decided to move my research focuses be closely integrated with my patients. Moved more towards computational human research. So pretty much all of our studies, my patients are my research subjects, and my studies are directly aimed to try to find better predictive tools and better treatments for those patients. And I miss the animal work, but it's for me the close link that my research interests and my clinical practice have make it much easier to bridge that gap.
Sounds like you've made the OR your laboratory in some sense.
That's right. Yeah, in many ways. That's right.
That's great. And tell us about some of the other hats that you wear, because you're on a number of different committees. You mentioned one of them, and you help with a bunch of different
right. Yeah. And I would say that's the third arm of my career, is really the societal work, because that's another. We number one, treat the patients. Number two, understand the disease so we can improve. But then number three, we really need to get the word out, and we need to advocate for patients on a broader level. And so I have a few different, I've had some involvement in the International League Against Epilepsy and the American Epilepsy Society and the North American Neuromodulation Society and the ASSFN. And I enjoy helping with these societies, obviously, and because I really think it's important both to come together as a community, to put our heads together, to think about scientific problems, to advocate for our field at a at a government level, and also to stay involved with each other and understand, network, see what everybody else is doing, so that we can improve our own practices. And so that's another thing that I've enjoyed is getting to more involved in the societies and really learning more about how other centers think, and how we may want to ideas we may want to incorporate into our own center. And so and
go ahead.
I also really appreciate you doing this. This is another, I think, great example of an initiative that I think has the potential to be very impactful in the field, making a podcast that's to make some of these topics accessible, and I think it's really, really important work. So I really appreciate you doing it in general, and also, of course, appreciate you letting me be a part of it.
Okay, well, listen, Dario, thanks again. We could probably ask you questions for the next few hours, because I find this Connectome work really interesting, and I think it's added a lot to the field. So thanks for the work you're doing, and we appreciate it, and keep up the good work. Okay.
Of course. Thank you, Luke. Thank you, Rohit. It's good to see you guys.
Take care. Bye-bye.
Bye-bye.
Thank you for listening to the Epilepsy Podcast. The video content and audio content is not intended to be a substitute for professional medical advice. The views and opinions represented here are merely the views and opinions of our expert guests. Thank you.